Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to this episode of the Radiology Review podcast. On this episode, I will be discussing hepatobiliary scintigraphy, which I'll simply refer to as HIDA scans. I will again present this in a question-answer format. Before I start, one quick announcement that I have made. What is a fairly complete list of quality control measures available on my website, theradiologyreview.com. That includes commonly tested quality control parameters and testing intervals for nuclear medicine, CT, ultrasound, MRI, and PET-CT. So go ahead and check that out. Now let's get started on this episode on HIDA scans. First question, all HIDA tracers are analogs of what? And I guess I should be more specific. All HIDA radio tracers are analogs of what? And the answer is aminodiacetic acid, which is the IDA part of HIDA. And aminodiacetic acid is a very close analog to lidocaine in chemical structure. A random fact, but it's something to be aware of. Next question. HIDA tracers mimic what physiologic process? The answer is that HIDA tracers mimic bilirubin uptake, transport, and secretion. On a HIDA scan, we're really essentially watching what bilirubin does as it passes through the enterohepatic circulation. And we watch the uptake of bilirubin in the liver, the transport of bilirubin through the liver into the biliary system, and the secretion of bile into the bowel and storage of bile in the gallbladder. Next question. If a patient has hyperbilirubinemia, what implication does this have for performing a HIDA scan? Another way to phrase this is, do we do anything different when we perform a HIDA scan on a patient with hyperbilirubinemia? The answer is that you must inject a higher dose of radiotracer due to competition with the bilirubin for uptake, transport, and secretion. So if bilirubin levels are high, your HIDA radiotracer will be competing with that bilirubin for hepatic uptake, and therefore you typically would inject a higher dose to improve the odds that the HIDA radiotracer will be able to have uptake in the liver for your imaging. Next, how long must a patient fast prior to a HIDA scan? The answer is that a patient must fast at least 4 hours, but no longer than 24 hours. Okay, keep that range in mind. You really need to know that one. 4 to 24 hours. So a patient must fast at least 4 hours. The reason for that is that you need the gallbladder to be in a relaxed state, and you need the gallbladder to not be constricted after a meal, but no longer than 24 hours, because after 24 hours, the gallbladder is packed full of bile, and the HIDA tracer will have difficulty getting in when it's already full. Okay, so again, at least 4 hours of fasting, but no longer than 24 hours of fasting. Next, if a patient has fasted longer than 24 hours, what must we do prior to performing a HIDA scan? And I hope you get this answer correct because it's important. So if a patient has fasted longer than 24 hours and they show up for their HIDA scan, what do you need to do? And most typically this would occur in the inpatient setting. And if a patient has fasted longer than 24 hours, you give CCK, and that CCK causes the gallbladder to constrict and empty, and thereafter the gallbladder will not be full and distended, so it will be able to accept the HIDA radiotracer as it gets secreted through the biliary system. If you image without giving CCK, the gallbladder is already completely full, and the HIDA tracer will not be able to enter the gallbladder, and you will get non-visualization of the gallbladder on imaging, which would give you the false appearance of cystic duct obstruction and acute cholecystitis. and we want to avoid false negatives, so we give CCK in that setting. What percentage of patients with acute cholecystitis have cystic duct obstruction? The answer is about 95% of patients with acute cholecystitis have an obstructed cystic duct. That really is the basis of why HIDA scans work, because we are able to image cystic duct obstruction, and thereby we are able to infer that acute cholecystitis is present, because about 95% of patients with acute cholecystitis have an obstructed cystic duct. Next question. What is the normal sequence of uptake and excretion that you expect to see on a HIDA scan? In other words, there are various phases of the HIDA scan. What are those phases? The answer is first, you see hepatic uptake, which causes clearance of the radiotracer from the blood pool. Next, you have excretion into the biliary ducts. Then you have excretion into the bowel. And then you have excretion into the gallbladder. Now, in some cases, you may see gallbladder prior to bowel, and that's not really important. But in general, first hepatic uptake phase, then excretion into the bile ducts, and then entrance of bile into the bowel and gallbladder. The gallbladder normally shows uptake on a HIDA scan within how many minutes? This is also really key, and I hope you all know it. So how long do we wait to see gallbladder on a HIDA scan? And the answer that I'm looking for is 60 minutes. So normally, in a patient without acute cholecystitis, you'll see the gallbladder show up on imaging within 60 minutes. Next question. How many minutes after injection of radiotracer do you typically start to see hepatic uptake? So one more time, you inject the radiotracer, and within how many minutes should you see the liver? And the answer is 5 minutes. Hepatic uptake is quite prompt. You should see it within 5 minutes. Next question, also important. What is the rim sign, and what does this mean in terms of cholecystitis? The rim sign looks like a curved area of uptake around the gallbladder fossa due to focal pericholecystic hepatic uptake. This results from reactive hepatic inflammation and hyperemia due to a very inflamed and typically gangrenous gallbladder. On board exams, the rim sign suggests that gangrenous cholecystitis is present. One more time. On board exams, the rim sign suggests that gangrenous cholecystitis is present. Make sure and always look for the rim of uptake around the gallbladder fossa within the liver. And if you do not know what the rim sign looks like, you need to add that to your list to look up because it is important for board exams. Next question. What is the cystic duct sign, and what does this mean in terms of cholecystitis? Think about that for one moment. What is the cystic duct sign, and what does that mean? The cystic duct sign is when you see a small focus or nub of activity in the proximal cystic duct with no activity distally. So you just see the tiniest portion of the proximal duct, but then the rest of the duct is not visualized. This means the cystic duct is obstructed, and therefore acute cholecystitis is present. Also look up that one if you don't know what that looks like. Next question. Is CCK administration used to evaluate for acute cholecystitis, chronic cholecystitis, or both? And I'm not talking here about the pre-treatment CCK that we talked about if a patient has been fasting more than 24 hours. You can also administer CCK during imaging, and I'm testing to see if you know why. Do we do that for acute cholecystitis, chronic cholecystitis, or both? The answer is that CCK administration is used to evaluate for chronic cholecystitis. CCK is not part of an acute cholecystitis evaluation. You only administer CCK once you see gallbladder filling. So therefore, not for acute cholecystitis, because with acute cholecystitis, the question is, do you have the gallbladder or not? CCK is only given when you see the gallbladder and you want to measure an ejection fraction. And this works because once you administer CCK, the gallbladder constricts and empties, and you are able to then calculate a gallbladder ejection fraction based on the emptying you see on imaging. What are manifestations of chronic cholecystitis on a HIDA scan? One is delayed filling of gallbladder with no filling at 1 hour, but it does fill by 4 hours. So we previously established that you should see the gallbladder within 60 minutes. If you don't, that can be a sign of either acute or chronic cholecystitis. So if you don't see it at 60 minutes, but it does show up by 4 hours, you have chronic cholecystitis. If you don't see it at 60 minutes and you still don't see it at 4 hours, you have acute cholecystitis. And there's one more manifestation of chronic cholecystitis other than delayed gallbladder filling, and that is gallbladder ejection fraction of less than 30% following CCK administration. So for chronic cholecystitis, there are two things you look for on imaging. The first is delayed gallbladder filling, and the second is a reduced gallbladder ejection fraction below 30%. Next question, and I also think you need to know this, unfortunately. What is the dose of CCK that is administered for a HIDA scan? Dig deep. Do you know this answer? What is the dose of CCK that is administered for a HIDA scan? And the answer is 0.02 micrograms per kilogram over 1 hour. You might find different sources having slight variations on that, but if you can remember 0.02 micrograms per kilogram over 1 hour, that should help you answer any questions on that. And emphasis on micrograms. This is not milligrams. It is 0.02 micrograms per kilogram over 1 hour, and that is our dose of CCK. Also important to note that this should be given over 1 hour. It's not a rapid push. If you give a rapid push of CCK, you can cause the patient pain, and you can also mess up accurate calculation of the gallbladder ejection fraction. So a slow infusion of 0.02 micrograms per kilogram over 1 hour is what we want for CCK. Now, when morphine is used during a HIDA scan, and we'll talk more about this later, but when morphine is used during a HIDA scan, what is the dose administered? I think you do need to know both doses for CCK and for morphine. So what is the dose for morphine? And here's the kicker. The dose for morphine is 0.02 milligrams per kilogram over 30 to 60 minutes. Some sources say something like 0.02 to 0.04, but I would keep it simple, and this is what I would remember. CCK, 0.02 micrograms per kilogram over 1 hour. Morphine, 0.02 milligrams per kilogram over 30 to 60 minutes. So notice 0.02 applies to both, but CCK is in micrograms and morphine is in milligrams. And you can remember that because think back to intern year or medical school when you were writing morphine orders, they were always in the milligram range, unless you were doing a drip. One more time, and this is the last time I promise, but I want you to know this. CCK dose 0.02 micrograms per kilogram over 1 hour. Morphine dose 0.02 milligrams per kilogram over 30 to 60 minutes. Next question. What does it mean if you see the liver on a HIDA scan but you do not see the biliary tree? Okay, you inject, you see liver but no biliary tree. What does that mean? This actually has a name, and lack of visualization of the biliary tree has been named the liver scan sign. And this is an indication of acute obstruction of the common bile duct. In this setting, you will see prompt clearance of the radiotracer from the blood pool. You will see prompt hepatic uptake, and the tracer will then be stuck in the liver and never enter into the biliary tree. And the reason for that is because the CBD, common bile duct, is obstructed, the pressure in the biliary tree is really high, and the radiotracer is not able to transit through the liver into the biliary system, and that's the liver scan sign. Next question. What do you look for to identify that there is persistent blood pool activity on a HIDA scan? How do we know if there is elevated tracer in the blood pool, which suggests that the liver is not working well? To identify persistent blood pool activity on a HIDA scan, you really should look in the cardiac region. And if you see persistent cardiac activity during the initial 60 minutes of imaging, this is a sign of persistent blood pool activity. Normally, you'll start to see the liver within 5 minutes, and you should see pretty rapidly the blood pool clear. If the blood pool does not clear, you have to think that there is elevated blood pool activity. So always check for cardiac activity on a HIDA scan to evaluate for this. And what does it mean on a HIDA scan if you have persistent blood pool activity with some liver uptake but no bowel activity? So one more time, you have persistent blood pool activity, you have some liver uptake, and you do not see bowel activity. This is a sign of hepatitis and or hepatic dysfunction. If you have no bowel activity but persistent blood pool, this is hepatitis and hepatic dysfunction. Okay, the liver is unable to clear the tracer completely from the blood pool, and it is also unable to have the tracer transit through the biliary system into the bowel. So that is a sign of hepatitis and hepatic dysfunction. Now, what if you have no bowel activity, but the blood pool clears normally? And what I just described is the liver scan sign, which is a sign of common bile duct obstruction. The key here is that the way we tell the difference between hepatitis/hepatic dysfunction and common bile duct obstruction is based on the blood pool activity, because in both settings, you may have hepatic uptake with lack of bowel visualization, but with hepatitis and or hepatic dysfunction, the blood pool will remain elevated, whereas with common bile duct obstruction, the blood pool will clear. That is a key point on a HIDA scan that I would know for board examinations, so pay attention to the blood pool activity. That is enough for now. I will continue the discussion on HIDA scans on our next episode of the Radiology Review podcast. I wish all the residents a successful new academic year, 3rd and 4th years. It is never too early to start preparing for your board examinations in 2021. If I have any new first-year radiology residents listening, welcome to the profession. You're in for a great journey. And remember, it is never too early to prepare to succeed. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.